Greetings. Let us learn about transjugular intrahepatic portosystemic shunt, otherwise known as TIPS. These are my acknowledgements, and please take time to read this notice. So, let us learn about transjugular intrahepatic portosystemic shunt. The shunt is placed between the hepatic veins and the portal vein by going through the liver parenchyma. And by doing this shunt, you decrease the portal pressure and it helps in the management of variceal hemorrhage. Especially when you have a patient with child's B cirrhosis with active bleeding at the time of endoscopy, esophageal variceal bleeding with child's B cirrhosis, active bleeding during endoscopy, and also child's C cirrhosis. If they present with bleeding and at endoscopy, even though you don't see varices, you do the banding. These two types of patients should be sent to TIPS within 24 to 48 hours or within the first 2 to 3 days to prevent further episodes of bleeding. TIPS is also used to manage patients with gastric variceal bleeding as well as ectopic variceal bleeding. In addition to prevention of bleeding and control of bleeding, TIPS is also used for management of refractory ascites. Refractory ascites is somebody on a salt-restricted diet, 2 grams of salt, and maximum tolerated doses of diuretics, spironolactone, and furosemide, or reaching a ceiling dose that is 400 milligrams of 400 milligrams of spironolactone and 160 milligrams of furosemide. And despite that, there is no mobilization of ascites. You call that as refractory ascites. It's also used for management of hydrothorax. So these are the 3 indications for placement of TIPS. And when you have a patient and you decided about doing TIPS, there are a few things you want to evaluate. And because you're placing the TIPS through the liver, and it's going to interfere with the circulation of the liver. Liver can get into trouble. Liver failure can set in. So you need to assess the liver status. Because you're placing a stent from one vein to the other vein, that is portal vein to the hepatic vein, you want to make sure that these veins are patent and not thrombosed. So you have to evaluate liver vasculature. And by placing TIPS, you are going to allow a lot of splanchnic circulation to reach directly into the right heart. And you want to make sure that the heart is in pretty decent condition to be able to accommodate this extra preload and extra pressures that are going to happen with this procedure. So you need to assess cardiac status. So at the end of this talk, we will review the physiology of TIPS. For now, we will figure out how to assess a patient for TIPS. So let us talk about how do you assess liver status. Uh, we all use MELD score. This is a score that gives how sick that liver is in that patient. And if the score is above 18, patients who undergo TIPS are likely to do poorly. They are likely to end up with liver failure. And another rough estimate is if the patient is obviously jaundiced and the bilirubin is high, at least above 4 milligrams per deciliter. So if there is indication that the liver is already sick and you don't want to make the patient worsen by placing a stent or the TIPS procedure. This is something you need to talk to patient when you're placing TIPS in patients with these conditions. Advanced liver disease identified by a very high MELD score of above 18, or if they have high bilirubin. Next is you assess liver vasculature. So this patient MELD score is 12, bilirubin is 2. That means we did taken the first step, and then we go to the liver vasculature. This is typically done by CT angiogram, or if the patient cannot go to CT angiogram, you can do ultrasound with Doppler studies. So when you go to CT angiogram, the radiologist will give you information about the vasculature of the liver, the drainage, the patency of the hepatic veins and IVC, and also the portal vein, whether it is patent or not, whether there's a thrombus or not. In addition, you'll also get information whether there is cysts in the liver, whether there's a hepatoma in the liver, whether that will interfere with the placement of the stent, and whether the bile ducts are normal or dilated. So all these pieces of information are really important before we decide about placing a TIPS procedure. So this patient has no hepatoma, patent hepatic vein, patent portal vein, bile ducts are normal. So the patient from the vessel's point of view is cleared. Then you assess the cardiac status by performing echocardiogram. And in echocardiogram, what you're looking at is cardiovascular function and whether there is evidence of uh, cardiac strain or cardiomyopathy or heart failure. And if there is any, or if there is any evidence of pulmonary hypertension. These findings will help you figure out whether the patient will do well after the TIPS or not. If the pressures in the heart or the heart is not able to take up that extra load that comes by placing the tips with a lot of blood flowing through the tips into the right heart, when the pressures are pretty high, then the flow through the tips will be slow and the tips is going to get into trouble with the development of thrombosis. So we have assessed our patient. Patient has relatively decent liver. MELD score is 12. Bilirubin is 2. CT angiogram showed patent vessels, and the echocardiogram showed the heart is cleared with a reasonable good function and able to take the load from the tips. So we decide to go for tips, and this is typically done in an interventional radiology suite under fluoroscopy and ultrasound guidance. So let us look at how the TIPS is performed. Typically you enter the jugular vein, right jugular vein, and then from there you pass a catheter down the right atrium via the superior vena cava, then enter the inferior vena cava. And once you enter the inferior vena cava, you measure the pressure in the suprahepatic portion of the inferior vena cava. You may take a measurement, and this pressure measurement is typically done below the diaphragm uh, in the IVC, just above the hepatic vein inlet into the IVC. And once you take a measurement, then you use a special needle under ultrasound guidance, puncture from the hepatic vein through the liver into the portal vein. And once you puncture, then using the catheter, you measure the pressure in the portal vein. So you have suprahepatic IVC pressure and portal vein pressure. And the difference between the portal vein pressure and suprahepatic IVC pressure is the portosystemic pressure gradient. So when we measured, this patient's pressure was very high, 22 millimeters of mercury. So you know that when the pressure is about 12, varices develop, and as the pressure goes up, they tend to bleed. So with this high pressure, this patient has certainly bled. So once you have these pressure measurements, the next is you go through the steps of placing the stent using a balloon dilation of the tract, and then after dilation of the tract and the liver, you place a covered stent. We are no longer using uncovered stents. So covered stents have replaced previously used uncovered stents, and these are self-expanding stents. As you remove the sheath, they open up. The stent diameter that we typically pick is an 8 millimeter stent, and it is important to deploy the stent in such a way that the proximal end of the stent opens into the hepatic veins at the opening of the hepatic vein into the IVC. So once you place the stent, you want to see whether you are able to reduce the pressure gradient between the suprahepatic IVC pressure and the portal vein pressure after placement of the stent. So the portosystemic pressure gradient after placing the stent has certainly came down significantly, and in this case it was 6 millimeters of mercury. So is that sufficient or not? So what we have learned is, if you could reduce the pressure gradient between the portal vein and the systemic vein to less than 12 millimeters of mercury, you've done the job. With a pressure below 12 millimeters of mercury, with a pressure gradient of less than 12 millimeters of mercury, varices will not bleed. If the pressure is 12 or above, varices are likely to rebleed. So it's very important to bring the pressure below 12 millimeters of mercury. So in this patient, we have done well, 6 millimeters, pretty good. We are happy with the 8 millimeter covered stent. The reason why we pick 8 millimeters instead of 10 millimeter covered stent is less portosystemic encephalopathy with an 8 millimeter stent. So let us take another case. Say, for example, in this patient, when you put the stent in, your pressure has dropped, but has not come down to below 12. It was around 14, 15 millimeters of mercury. So in that case, what do you do? Nowadays, the stents have special function where you could actually balloon dilate the stent for controlled expansion to 10 millimeters diameter. So with that, the pressure should drop. So let us see whether the pressure dropped. And actually the pressure dropped, but it didn't drop to below 12. So it was 13. So what do you do when you place the tips, the pressure dropped, but did not reach the target of less than 12 millimeters of mercury? In those patients, you could actually help the patient by starting them on a non-selective beta blocker. Normally, if you put the stent in and the pressure drops, there's no need for a non-selective beta blocker. But if the patient's portosystemic pressure gradient does not come below 12, despite increasing the stent size to 10 millimeters, then adding a non-selective beta blocker like a carvedilol, nadolol, or propranolol will be useful. So we have learned about a few principles. Size of the stent, 8 millimeters. Covered stent, gradient should be less than 12 millimeters of mercury between the portal vein and the suprahepatic IVC. And if it doesn't come down, increase the size of the stent to 10. And if it doesn't come down, add non-selective beta blocker. So once the patient comes back to the ICU after the procedure, you should monitor them very closely and also start some prophylactic therapy because these patients are likely to develop portosystemic encephalopathy. One should also be careful about possibility of liver failure after the placement of the stent. This can happen especially in patients who have advanced liver disease with a high MELD score. The stents can also develop thrombosis or dysfunction, especially if they have a heart disease with high right atrial pressures and the gradient is not enough for the flow, and then there is a sluggish flow could lead to TIPS dysfunction because of thrombosis of the stent. And when you suspect that, you could actually check it by doing a Doppler. So that's one way to check. So we've learned about TIPS, and before we conclude, I would like you to understand the hemodynamics after placing the TIPS procedure. What happens after you place the TIPS? Pressures on the right side of the heart increase, right atrial pressure increases, right ventricular pressure increases, pulmonary arterial pressure increases, pulmonary capillary wedge pressure increases. There is increase in the preload because of volume, and then it increases the cardiac output. And because of increase in cardiac output, the benefit is the renin, angiotensin, aldosterone system is downgraded, and that is what is helpful in managing the refractory ascites. And also there is increase in renal function. So these are all the benefits of TIPS, and we also learned about some of the drawbacks of TIPS. I hope this is helpful, and I want to thank authors of this guideline from AASLD. Hope you take time to read this, and thank you.